Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. This is episode 10, the final episode of season 1 of the Bad EM podcast, and this month we're chatting to Dr. Sandy Inglis. He's an emergency medicine physician originally from Pietermaritzburg, who has worked all over the world, picking up a colorful variety of experience in high and low income countries, conflict zones and remote areas. We chat about what different healthcare systems can learn from each other. We speak about emergency medicine as a whole and the critical overlap between primary and public health. And then we move on to his more recent humanitarian work for the International Red Cross, specifically in Gaza, where he has spent most of the last year. As always, views expressed are purely personal and do not represent any organizations that either myself nor my guest represent. We also apologize for some bits of poor sound quality as this episode was recorded remotely. Welcome to the show, Sandy. Would you start by introducing yourself and giving us a background of your professional career so far?
Well, Dan, thank you. Thanks very much. And thanks so much for having me on your podcast. A real pleasure to be here. And in fact, of course, I'm going back to my roots because my career started in Cape Town. I trained in Cape Town and in fact did quite a bit of my time at Victoria Hospital, right where you are now. And then I've gone right through to where I've been this year, which has been mostly in Gaza, and then lots of little bits in between. I think my career has probably been very much the sort of ultimate in peripatetic emergency medicine, in that I've somehow managed to move between quite a few continents and worked in quite a few different places. After Cape Town, I was up at Edendale in Pietermaritzburg, did my intern years up there, and then moved pretty rapidly to the UK, where I was for about 2.5 years doing locums here and there, and started as a GP trainee in Pembrokeshire and Wales. And then from there, I moved off to New Zealand, where I initially thought I'd continue my GP training, but then very rapidly was moving into the realm of sort of remote medicine in one form or another, and started training myself for that. Ended up in an ED in Christchurch in the South Island of New Zealand, and fell in love with emergency medicine and really never looked back. The amazing thing about that was, and I feel this quite strongly, is we don't choose our specialties. I think our specialties choose us, and that clearly happened to me, where I ended up in an ED, found kindred spirits, found an ambience and a professionalism and an ethos that worked for me, and pretty much has for my entire career. So mainly New Zealand initially, and then continued my training in the west side of Australia, back to New Zealand for initial consultant jobs. And then I've since then sort of zigzagged back and forth, done time in the UK, in various EDs there, back to New Zealand. And then living in New Zealand, I had this desire, I think, mainly to introduce my kids back to the world of South Africa and Africa. I didn't want to end up in a big ED in one of the main centres, so got a job as a chief medical officer at Imsileni up on the Mozambique border. Yeah, I ended up at Imsileni on the Mozambique border. And, you know, in your life, you look back at some of your career moves, and that has to be one of the best moves I ever made. Not only from a cultural and life experience for me and my family living in a remote area of South Africa, probably one of the more beautiful places in the world, in that you've got some of the best game reserves in the world, scuba diving on weekends, trips into Mozambique and so on. But just to be taken completely out of my comfort zone, which was emergency medicine, and of course you didn't have a job there as an emergency medicine physician. You had a job as a a general doctor, and you know as well as I do what these jobs are like. Yeah.
Yeah, you have to do everything. Yeah.
Yeah, you do everything, and sort of on you know my third day there, I was on call for labour ward, and you know what that's like, and you know within about 5 days you're cutting cesareans, intubating neonates, and dealing with everything else. So absolutely amazing life experience. So we travelled around Africa for about 6 months after that with our kids in a 4x4. I worked in Rwanda for a few weeks in a mission hospital. And then visited various health facilities on our travels in Malawi and so on. Back to France briefly to continue renovating a house, and again work in the UK whenever I was in France. And then probably my next greatest career decision. Funny enough, I got offered an excellent job on the east coast of Australia, on the Sunshine Coast, with all the perks and all the a lovely package. And my very good colleague, George Oosthuizen, was trying to get me to come back to Edendale in Maritzburg. Unfortunately for me, my wife wasn't keen on going to Australia, and so Edendale won. And we spent about 5 years back in Pietermaritzburg, where we got emergency medicine going in Maritzburg and wider in KZN, and set up and developed the ED at Edendale. And yeah, a really spectacular 5 years, amazing pathology, amazing to be able to bring skills back from other countries and high quality training, of course, from Australasia, and to be able to share that not only back in my own country, but back in my hometown, because Maritzburg is where I'm originally from. Ultimately, after that, we had to make the big decision. Daughters were getting to university age, and it was where to next. And having had this house in France, it was an easy move back to France, and then I worked in France for an initial 6 months, but France didn't give me credit for my training, my fellowships elsewhere. They wanted me to write more exams, and in fact, the French system, I didn't quite adjust to it. It's very much a pre-hospital system, quite different to the systems you find in Anglophile countries. I did locums. I had a long-term locum in Iceland, so I went back and forth to Iceland. I did telemedicine to Australia, which is useful from an income point of view, but didn't quite tick the boxes from a career point of view for me. And then having been in a situation where I was living in Europe, looking for the next sort of chapter, then moved very easily into the humanitarian world, which I've been in for the last four years, and with jobs in Bangladesh, Sudan, Geneva, and then more recently in Gaza. So that's a bit of a whirlwind through it, but yeah, pretty much all over the place, and now having a brief break. Yeah.
And what is your current job title at the moment? I believe you work for the Red Cross, and you doing work in Gaza. You've done work in Sudan and Bangladesh and everywhere. But what is your current job title?
Yeah, so it varies. Right now, this year in Gaza, it's been what's called a Senior Medical Officer, or SMO, for a field hospital in Al Mawasi near Rafah in Gaza. But how these jobs work is that they short-term contracts. So the International Committee of the Red Cross will contract you sort of 6 weeks at a time, because really you probably don't want to be there for more than 6 weeks. And then what they do is I do 6 weeks, and then you have time off, and then they just renew your contract and they keep rolling it on, which I love, and it suits me very much. The SMO job is very much it's a clinical manager job. So you're sort of the clinical director for a field hospital. But what I've loved about it is that I've been able to support the emergency department. So in a way, you've ended up with 2 emergency physicians and an SMO. And in fact, I believe in those contexts, an emergency physician is probably the best person for the job, just because you've got those broader skills and you're completely comfortable in the mass casualty or trauma setting.
And a generally problem-solving attitude towards things.
Yeah, very much so, Dan. Yeah, yeah, that's right. Nothing's too difficult. And the amazing thing about it, it's not only the emergency medicine thing; it's the South African thing as well, where people will come to you and say, Sandy, we've got this major issue. We can't, this. We've got to try and work out this, or without going into details, and it'll often look so simple to you, and I often think, gosh, that's from my time at Insulani or my time at Edendale. That's given you those skills to help with complex, what seemingly are complex issues in a situation like Gaza.
So that leads us quite nicely into our next question. Is you are a trained emergency physician, but throughout your career, as you've already touched on, you've worn a lot of different hats, from a primary care level at various places. As we know, lots of emergency departments provide lots of primary care, to a more managerial role, to a humanitarian role, and a more public health sort of role with setting up hospitals and things like that. How do these overlap, and how important is it to actually perhaps not have a specific brand and just approach work as, like I said, in a problem solving manner, and provide a service to what the people that are there need, if that makes sense?
I think I've been extremely fortunate in my career. I mean, even as a med student at UCT, I used to go back to Pietermaritzburg for the longer holidays. And I had holiday jobs at Gray's Hospital. And so I started as an orderly pushing stretchers around, collecting patients, then worked as a ward nurse, then as a theatre nurse. I've worked as a GP trainee. I've worked in rural hospitals and in various different types of emergency departments and different contexts. And I think all of those skills have been all of those experiences have been enormously helpful in my job as an emergency physician today. And I think the emergency department is very much a continuum of all those areas of primary healthcare, of public healthcare, and of emergency medicine. And of course, we manage an enormous amount of primary healthcare. We manage public healthcare and ED, and GPs manage emergencies and public healthcare. So they all very much interwoven and interact. And depending on which of those areas you eventually end up in, obviously will be the predominant component of your job. So I think my experience has given me a huge advantage in the emergency medicine arena to address those different aspects of the job. I mean, in Gaza recently, we did a polio vaccination campaign. Okay, it was more wearing my SMO hat, but it was very much, involved emergency medicine, involved our primary healthcare clinic, our GPs, and all of it was integrated to provide that service. Every day in the ED, I mean, we've seen the consequences of poor public health, whether it's ischemic heart disease or lung disease or road traffic accidents. So we've got an obligation to understand all those areas of our health systems, to promote each of them, whichever area we happen to end up in, and to be educated and trained in each of those areas as well. And that's going back to undergraduate. We need to know about public health and general practice, and even in our ED training, to concentrate on those aspects, because they're completely relevant to what we're doing. And the old adage of being the ambulance at the bottom of the cliff. Emergency medicine, we can't just be the ambulance at the bottom of the cliff. We've got to contribute at all levels of that continuum.
That's a good metaphor. Can't just sort of pick up everything and try to fix it when everything's broken already.
Yeah.
So in South Africa, we work in a complex healthcare system. We are theoretically a lower middle income country, but we have a dichotomy of services offered. some akin to high-income countries and some akin to low-income countries, depending on where one works, even within the government healthcare system itself. You have worked in some very high-income countries and some very low-income countries. What can we learn or take from the different systems that each have their benefits but also have their pitfalls?
So, I think, again, I'm incredibly fortunate to have trained in South Africa and then moved into, New Zealand, Australia, Iceland, France, the UK, and having worked in really the extremes. I worked in a place called Kassala in the east of Sudan, where we had nothing. We couldn't even take a blood pressure. We had nothing. In fact, as a doctor, I felt almost useless because I thought, I haven't got the tools of my trade. What can I do here? And so there are not many people, I think, nowadays who are in that situation. My daughter's training as a doctor in Brussels at the moment, and she's training into the top end of the high income countries and all the resources they've got. But definitely, we've got a lot to learn from both systems, and both systems have their advantages. I think the sophistication and the equipment and the staffing and the protocols and the systems of the high-income countries are spectacular. And when I walk into one of those EDs, it might be in Reykjavik, in Iceland, the Landspítali Hospital, I don't think I've ever seen an ED that's so well equipped and so well staffed. You'll have half a dozen ultrasound machines lined up. You'll have your Lucas defibrillators sitting there. Anything you need is there and accessible. And obviously in low-income countries, a lot of that stuff doesn't exist or might be broken and or it may not be available. But both systems obviously add value to the patient care, and it's about taking the best of each world. And I often have this sort of vision in my mind of a sort of utopian ED that can draw on the best of both those worlds. I think the lower income countries are far more pragmatic in their approaches to emergency medicine. If someone comes in with a headache to a low income country ED, we examine them, we take a good history, we try and understand what's causing this headache and why they've got a headache. And as you and I know, most of the time, it's a simple headache, and we can treat it with a bit of paracetamol or some Nurofen. If it's not a simple headache, we'll be thinking about, migraines and tension and cluster headaches and so on. And we'll address that. What's happening now in the higher income countries is no one's got a simple headache and no one's got a syndromic headache. Everyone gets an MRI now if they've got a headache. When I go back and do these locums, I'm frequently left speechless, where my junior doctors will come up to me and say, can you just have a look at this MRI result and tell me what you think? And I said, what do you mean? And they say, just see.
Why did you get an MRI?
Yeah. What do you mean? And exactly that. This patient has had a headache for a day, and so I just ordered an MRI. And it's literally got that easy. I remember when CT scans, I remember some years ago saying, they use CT scans like chest x-rays now. Well, that's almost happening with MRIs now, And we see it in many aspects. You see the sort of terminal palliative care cancer patient or advanced liver disease alcoholic who's on his deathbed, who arrives in ED, and you'll find one of your colleagues has intubated him, started inotropes, put up a central line, and he's on a ventilator. And I walk in there and look on with complete horror because it just seems so wasteful and inappropriate and frankly quite sad that someone's going to end their life like that in an intensive care where they shouldn't be. So, so although there's amazing stuff on each side, somehow if one can have a system where one can merge aspects where you've got an amazing ultrasound machine that works well, your EDN monitors that work well, and you've got the drugs that you need and the space to put patients, but then you're still making reasonable, pragmatic, sensible, useful decisions about your patients. And I think that's probably the best message I've had from my movement between these almost different worlds of emergency medicine. I've come out of Gaza now. I'm going to be working in Iceland for the whole of November, and then I've got a locum in Geraldton in Australia in January. And so you move from these different contexts, and each time it's a complete reality check. And personally, I always hope that I'm taking some of my sensibility to those environments, that one can do what you hope is reasonable. The slight risk, of course, is that you arrive in a context like an ED in Australia, and you say, oh no, don't be ridiculous, this doesn't need an MRI, or this doesn't need intubating. And you sometimes can be frowned upon as, oh, this is sort of the South African cowboy, what does he know, so you sometimes have your arm twisted a bit to conform to the local expectations, even though it's against your better judgment. And that's tricky, and that you just got to navigate as it comes. Yeah.
And speaking of that expectation, you're obviously speaking about an expectation from other doctors and healthcare professionals, but also there's an expectation from patients. How have you found expectation from patients and populations affects the almost, if I can put it, like the perceived quality of care that you are providing? For example, you obviously take a lot of job, or we all do, take a lot of job satisfaction from perceiving that we are providing a quality service to somebody. That makes us feel good. That makes us go back to work the next day. And in a lot of high income countries, the UK springs to mind, there's a lot of media, public backlash or sort of negative press about waiting times, about ambulance piles up, about how poor their healthcare service is, about how nobody likes to be treated at the NHS, etc., etc. That's obviously a simplistic view. But then if you're working in a place like Gaza or Sudan, you said, where you can't even do a blood pressure, there's probably quite a public perception that they are very grateful to have you there. And even if they are receiving a much smaller objective service, objective quality of medical care and speed and efficiency and investigation capacity, all of that, they make you feel like you are providing a much better service just by being there and being available and being present. So how do you feel that the public perception affects the perceived quality of care that you are providing?
Yes. So interestingly, it's not a simplistic, sort of a logarithmic relationship. If you're in a high income country, the expectations are very high, and if you're in a low income country, they're very low. Okay. So it's not always like that. I mean, I remember I was working in Cork in Ireland about a year ago, and I ended my shift at about 8 o'clock in the evening, and was walking out of ED, and I sort of greeted this man sitting on a chair. I came back the next day for a day shift. The man was still sitting on the same chair, having not been seen, and completely accepting of, he wasn't complaining, he was sitting there, and I know he hadn't been seen, but he was a green code and he was waiting. So that's a high income country with a very dysfunctional health service. Ireland pretty much mirrors the NHS, regrettably. But, I suppose one can generalize, yes, people in high income countries expect a much higher level of care, and then you get more complaints, more litigation, and higher expectations. but it's not necessarily a clear relationship. In Gaza, again, um, you know, we're in a field hospital in a war zone, but I have patients there with incredibly high expectations. Like, no, I want to be referred for a CT scan, And interestingly, the Palestinians are used to a high level of healthcare. Gaza and the whole Gaza Strip, the whole Palestine are used to excellent hospitals. I mean, Al Shifa Hospital that's been destroyed had all the specialties, had MRI, had chemo, radiotherapy, high quality care. So even though we're in an absolutely extreme emergency situation there, people still have expectations, and that's not necessarily going to change just because of the situation or because they're high or low income. So I think one's got to be careful drawing those generalizations related to the context. I think broadly speaking, yes, I've many times in Australia where someone's sat in the waiting room for 4 hours, something pretty trivial, a small cut on the finger, and then give you a very hard time because they've waited, they're not happy with the care they've had at triage or whatever. But I think one's just got to be cognizant of the fact that it may not always be quite as clear as you think it is.
Yeah. Do you feel better about yourself and the job that you're doing when people are more appreciative of your care despite the circumstances?
Yeah, I think there's no doubt. I mean, we all love that positive feedback. I think emergency departments, unfortunately, a lot of the time are not places where you get a lot of either praise or gratitude. And I think it's often understandable. People are stressed and rushed, and they're busy, often chaotic environments. But yeah, there's nothing that gives me more joy than when you have achieved something in the ED, whether you've sutured a small wound or pulled out fish hook out of a finger or thrombolized someone for that matter, and people do show their gratitude and are happy with the service you've given. It's a huge joy, and I always have this little thing where I ask myself every day when I've been in an ED, have I made a difference in someone's life today? And I think we probably all hard on ourselves because I'm sure we make a difference in a lot of people's lives. But I like to be able to think of a particular case during the day and say, it might be something like reduced disced shoulder. And the patient was so happy, and there's a mountain biker, and they really thank you, and you have a good chat about cycling, whatever it might be, and that leaves me feeling fulfilled and satisfied, even if it's just one case amidst all the other chaos and issues and problems and maybe complaints. It definitely is a very positive thing when you have that feedback.
So to move on from a systems and public health thought process, should South Africa, like I said, with quite a dichotomous high income versus low income service provision system, and we service across the board in different settings, should we be, well, firstly, a lot of the protocols, a lot of the teaching, a lot of the cutting edge stuff is coming from high income countries, whereas I think South Africa, in a lot of situations, is more similar to, for example, the BRICS nations like India and Brazil. We've got huge demand and not as much supply in terms of resource, funding, staffing, space, hospital beds, etc. Should we be teaming up with them and looking for advice and system design and things like that from more similar countries? Or should we be continually striving to match the provision of high income countries?
Yeah, I mean that's such an important question, and South Africa is so perfectly poised to try and get that right. And I I definitely think we need to be looking at what's done in the lower income countries. And actually, I don't think we can call India a low income country anymore either. It's probably very similar to South Africa, maybe Brazil and so on are as well. We definitely need to be taking lessons from them. I think South Africa is in an interesting position in that we potentially can take the best from both worlds. So there's a lot of lessons to learn from the Australasian system, from the UK, from Europe and the US, of course, and yet draw on the more pragmatic and practical lessons from the countries that are more consistent with our level of healthcare. The trap we don't want to get into is obviously that example I gave you about MRIing every headache that comes in the door, because obviously I think the high income countries are probably going to sink because of that approach. So it would completely decimate the South African health system if we tried to position ourselves with a healthcare system at that level. Obviously, South Africa is also confusing in that we've got private and public healthcare, and so that adds a new dimension, because the impression I got when I was there with my brief time in private was that private is offering very much a high-income country healthcare level, and the public system is offering a very different level of healthcare, and that creates a very, very visible discrepancy and conflict in the healthcare that's provided.
Often trying to keep up with the private level in our own country.
And the difficulty thing is, a lot of the protocols are coming out. Someone's got pleuritic sounding chest pain. Oh, it could be PE, right? We need a CTPA. The protocols direct us there. And we do in Australia, we do CTPAs liberally. You just don't want to miss a pulmonary embolus. So you use your whatever scoring system you might use, and off you go, and says, right, needs a CTPA. And the risk with that in South Africa is that we just can't do CTPAs on all those patients that flock into Victoria or any of the other EDs that are around. So I think we've somehow got to adapt the high income strategies, protocols, management guidelines and so on, but to our context, and say, right, that's fine, but this is what we're going to do here. I mean, I was hugely impressed when I was at Victoria, and I work in a lot of EDs now where we just look at an ECG, look at a patient, write MI, phone up the cath lab, and off they go, because they're in the cath lab getting thrombolized. I mean, I can't even remember the contraindications and or the minutiae of the indications for thrombolysis, because I don't have to anymore, because they go to cath lab. Whereas, on the round there at Victoria, you guys were dissecting the minute details of the pros and cons and contra and indications for thrombolysis. And I think, I can't remember if you had alteplase or streptokinase, but
we've got both, but alteplase is more expensive.
Yeah. So there's a beautiful example of, someone presenting with an acute coronary syndrome requiring intervention. Okay, we can't send them all to cath lab. It's not going to happen, but we've got a very good alternative which works very well, and that's what we can do. So, yep, we've got the high standards, we've got the high diagnostic algorithms, but we don't have a cath lab right there, or it's only available in daytime or whatever the case might be, and potentially have a very good outcome. So, and I think we need to be looking at that in so many other clinical situations. The pulmonary embolus one is a good example. Approach to headaches. So many, who gets intubated. End of life care, palliative care, etc. There's so many examples of I'll be looking at a patient. And I'll be in my ED in Reykjavik in Iceland, and I'll think, at Edendale, I would be doing this, but because I'm in Reykjavik, Iceland, and the expectations of this, and this is what my colleagues here are doing, we're going to do this. And it does create conflict for me from a sort of, I suppose, ethical, moral, and a pragmatic point of view into what I do and what I think should be done. But because of the risk of litigation and a whole lot of other reasons, one has to conform with what's done in that setting.
Yeah. For example, in India, I don't have much knowledge of the healthcare system, and I'm not sure if this is an official thing or not. But I've been there, and I know that you can go to a pharmacy or apothecary, like along the street, and pretty much buy any medication you want, including what we would typically need a prescription for in South Africa, and I'm assuming most other countries. And I was thinking about that because I was there quite a long time ago, and I found it quite amusing that, okay, well, here's just a bit lax on the laws. You can just go and do that. But more recently, I was thinking about that and thinking to myself, there is a increased risk on the patient and the provider. But if everybody accepts that risk, if everybody says, okay, well, this is how it is here, I don't think I need to go to an emergency unit for this. I don't think I need to go to a GP for this. Although that might be a bit lax, and although that might carry a bit more risk for everyone, that's probably only a bit of risk compared to the benefit it provides on the demand of the system. So, as I can imagine, those things would be very difficult to regulate for a government. And the system is very non high income esque in terms of its safety and risk profile. But then again, in terms of the access to what people need, India serves over 1 billion people with a healthcare system that has far less resources than some high income countries serving much smaller populations. Or what do you think of that?
Yeah, I mean, I think, yes, I've seen the Indian system as well. And I think it is amazing because it allows access to a whole lot of remedies. But of course, it's not without its risk. Those little pharmacies on the street, and I've seen it in Gaza as well. They're selling diabetic medications, they're selling antihypertensives, beta blockers, all sort of things that potentially could be causing a lot of grief out there. So I certainly wouldn't advocate that. I like the idea of easier access somehow, whether that means easier access, more pharmacists, more primary health care probably, but untrained people selling medications in street kiosks, I think is pretty risky, and I don't think that would be a good idea in South Africa. But I think that's where an emphasis on our primary healthcare system would likely address that. We've all heard about the primary healthcare model in Cuba, and we have a lot of Cuban doctors in South Africa who've come out of that system. And there they seem to have a spectacular primary healthcare system with very easy access, and that has roll-on effects for your public health and for your EDs. And we addressed this earlier in our discussion. One of the impacts of having a poor, I suppose, training or relationship or understanding of primary healthcare, public healthcare, and emergency medicine is that if your primary healthcare or your public healthcare is poor, obviously your EDs are going to get hammered. And we're seeing this more and more now. And clearly, to me, it's not sustainable. I mean, I'm really worried about the EDs of the future because if this model continues, those EDs are going to implode because, I mean, Australia, they have what's called ramping. So ramping is when paramedics and pre-hospital teams just ramp on the ambulance ramp outside. And those guys will ramp for 4, 6, 12 hours waiting to get into the ED. And what's happening in the ED is the EDs are getting absolutely flooded with primary healthcare problems. People with toothache and, poorly controlled asthma or whatever it might be. So, I think we need to more and more, and particularly in the lower income countries, but this would apply to the high income countries, is to address vigorously our primary healthcare and public health, because that'll have roll-on effects, obviously, for every other aspect of our healthcare, including our EDs.
Let's talk a bit more about your recent experience in Gaza over the last year. How does one depoliticize healthcare and aid provision? So, regardless of any political views, there's quite clearly a innocent population that is in desperate need of healthcare, and you, with your organization, are going into a very unstable, perhaps unsafe environment for yourself and providing care. How do you step back from that mentally and emotionally and try and provide a service in a rational way?
Yeah, I'm employed in Gaza by the International Committee of the Red Cross, which is a Geneva, a Swiss-based organization providing humanitarian care in areas of conflict. So only works where there is war happening. And the International Committee of the Red Cross is governed by the Geneva Conventions relating to IHL, which is international humanitarian law. But its cornerstones are its almost fanatical commitment to impartiality and neutrality and independence from interference from anyone. So even within Gaza, we don't have any relationship with the UN. Okay, we have a very loose relationship with WHO in the transports in and out of Gaza, and in all our security arrangements, we're completely independent of the UN transports in and out of the country and so on. So we have our own ICRC bus, and the UN and all the other organizations use another transport to get in and out of Gaza. So because of that neutrality and independence and impartiality, that is our mandate for everything we do. So when I see patients and our wards full and our EDs at the field hospital, all of that is done under that umbrella of impartiality. So it's completely depoliticized. And ICRC has a dialogue with all parties to any conflict. So, and that's why ICRC can keep functioning. So, for example, in Sudan, I was there pre the latest revolution, which happened pretty much as I was there, and then I left shortly afterwards. But the ICRC, when it's working in a situation in a country and then there's a revolution, doesn't just pack up and leave because they don't have to, because they continue to work there and function with the new dispensation, whatever that might be. And it's exactly the same with Gaza. ICRC has dialogue with all parties to the conflict, and that allows us to do our work in Gaza with a completely apolitical and impartial approach. So as a doctor and in the ED, we're getting obviously severely injured, weapon wounded patients, and never do I have to even ask that question because it's not even on my radar. I just see what's in front of me and we do what we have to do. And that allows us to work there in a completely apolitical fashion. Obviously, around that, political discussions do happen, but we never allow that to influence our day-to-day work and our approach to our patients and our injured around us. So, and so just to add to that, for our safety and the safety of our field hospital and the safety of our colleagues and of our resident colleagues and our patients and everyone, it has to be apolitical. It has to be impartial, because at any stage, if you drift into the realm of politicizing our healthcare our situation would not be tenable there. We'd have to withdraw from that situation. We could not work there without being completely apolitical. Yeah. One cannot let one's own personal opinions permeate your work there, because you won't be able to function at all.
Yeah. And do you feel safe working there, or do you feel unsafe working there?
I have complete confidence in the security arrangements of the International Committee of the Red Cross. So we see and hear cannon and explosion fire going on virtually all the time. We frequently have to retreat to what's called our safe room, which is a steel shutters on the windows and doors on the ground floor. We watch shooting happening, and but despite that, I feel safe. Our area is what's called a deconflicted area, so the Israeli Defense Force know exactly where we are. They know our GPS coordinates. Our field hospital and our residence is clearly marked with the Red Cross emblem of the International Committee of the Red Cross. So it can be seen from the air. It's illuminated at night. So, they know we're there, and they know they have to avoid us. We're in what's loosely called the humanitarian region of Gaza, which is that bottom southwest corner. But, the conflict is all around us. But within that, I do feel safe, and I have confidence that the security arrangements will keep us safe. But that said, healthcare workers are continually victims within these conflicts. Hundreds of our Palestinian colleagues, ambulance drivers have been killed, doctors have been killed, obviously hospitals destroyed, all of which is in complete opposition to international humanitarian law, where health workers should be protected. So despite my personal feeling of security, I feel that the broader security of healthcare workers in Gaza, and I'm speaking particularly for my Palestinian colleagues, is far from safe.
Yeah. Okay. Last question. So not necessarily about conflict zones or humanitarian medicine or anything really. It's an open playing field. If you had a magic wand and could wish for one tangible thing in healthcare in the world, because you offer a very worldwide perspective, perhaps in line with emergency medicine, that could materialize tomorrow, what would that be?
Yeah, I think particularly related to emergency medicine, I often have this dream, I suppose, or vision of a sort of utopian emergency department. And I remember even thinking about this when I was in Pietermaritzburg, how I'd love to open an emergency department that wasn't governed by finances or by expectations or litigation and so on, but rather governed by a sensible, pragmatic, evidence-based approach to clinical and emergency care. So where you had an emergency department and you had your ultrasound machine and your CT scanner, and you could refer people for specialists if required, but that you weren't hindered by, oh my God, I better just do a CTPA because, you just don't want to miss a PE here. But your gestalt is totally, comfortable that this is not a PE, but you try to keep someone, almost someone else happy. But that's not the case. So I think it's a health system where high quality but sensible, fair, and cost-effective healthcare is provided. A health system where the public and primary healthcare system is robust, so that EDs are not flooded and can provide the emergency care that they should be providing, because our primary healthcare colleagues are well resourced and equipped to keep people out of emergency departments, if you like, and a public health system that, again, is robust, and kids are being vaccinated, and people are wearing seatbelts and aren't drinking and driving, and all the usual messages are out there to avoid them ending up in ED. So I think your question reflects nicely back to almost where we started, is that if the public health system's working, if your primary healthcare work is working, then your EDs can provide a very high level of appropriate and reasonable and cost-effective and evidence-based care at the level that it should be provided. So I think if I had a magic wand, it would be to try and mend those three aspects so that they can work in harmony with each other to provide the sort of healthcare that we all know is needed and is expected.
Well, when you find that utopian emergency unit, let me know and I'll come work there with you.
Yeah. Amazingly, Edendale was chaotic and obviously a lot of problems there, but in a lot of ways, I often feel that some of the emergency medicine we practiced there was amazing. It was very sensible, it was very high level, and it was very pragmatic and well supported by our specialist colleagues. So I sometimes think that was almost as close as I got. But then, of course, the primary healthcare and the public healthcare needs a lot of work. So we've got a long way to go. Yeah.
Quite ironic that after going all over the world, the closest thing to what met your needs was in Pietermaritzburg, after all.
Yeah.
Have you got any final thoughts for our listeners before we finish off?
Dan, I think, just a message from me is, I think emergency medicine, for anyone out there who's thinking of specializing in emergency medicine as a career choice, I couldn't imagine doing anything else. In a way, it's been my ticket to the world in a lot of ways, not only from a professional point of view, but from a cultural point of view, from an adventure point of view, and so it's been the most spectacular specialty where no day has ever been the same. It's given me amazing flexibility. I'm not working now for a month as I rest up. I think I'm hugely grateful to have had that opportunity in this specialty, and I would certainly advocate it. And I think there's obviously a lot of work to be done in emergency medicine, and hopefully we'll get more people involved.
Awesome. Well, thank you so much for joining us, and really appreciate your time. And I'm sure a lot of people will find that very interesting and informative.
Thank you, Dan. Yeah, absolute pleasure and great to chat. Thank you.
All right. That's all for this month, everybody. To recap the episode quickly, we spoke about Sandy's career across the globe, about how high income and low income countries each have their pitfalls and benefits, and how we should learn from both. We spoke about how public, primary, and emergency care all really merge into one, and how we need to know about all of them to do our job to the best of our capability. And then we ended off by chatting about working in Gaza, and although he feels safe, the same cannot be said for the hundreds of Palestinian healthcare workers, other aid workers, and civilians who have tragically lost their lives. As I said in the beginning, this is the last of the 10 episodes that make up season 1 of the Bad EM podcast, and I just wanted to thank everyone who has taken the time to listen and share this project of ours. We have reached thousands of people and maybe some bots in 56 countries, including 18 African countries, which was ultimately the point in the first place. We are looking forward to season 2, which will come out in January next year, where we hope to continue to share ideas, problem solve, and engage with interesting people who have things that are worth talking about. In the meantime, please contact me on dan@badem.co.za and visit our website www.badem.co.za for more content. We will also be at the African Conference of Emergency Medicine in November in Botswana, so if you are there, come and say hi and we can share ideas. Please like and share with your friends and colleagues, and we'll see you next year. Bye bye.